Hi, this is Sakwir Broad. Today I'll be talking about an insulin overdose. Overview. Mr. H, who is an elderly patient who suffers from diabetes, requires surgery for ischemic bowel. Mr. H's ischemic bowel condition was diagnosed subsequently after the first surgical incision, where he has been experiencing an extended and rigid abdomen, which is especially dangerous for someone of his age. Directly prior to his surgery, his vital signs and blood sugar level were within normal range. He has an IV tubing attached to him. Mr. H kidney function started to decline. His surgery and potential outcome is of high risk due to his age, his condition, and the fact that he loses a lot of blood throughout the duration of the procedure. As the transfusion is happening in the OR, his kidney function continues to decline. He received 10 shots of insulin due to senior resident not paying attention to the unit in the doses. He should have received 10 units of insulin, but in actual, he received 10 ml of an insulin. The result of this is causing medication error and Mr. H receiving a deadly overdose of an insulin. Errors that occur included poor packaging of insulin, meaning illegible numbers or lacking numbers, nurse fatigue, miscommunication, administering the subcutaneously insulin to the intravenous route, and by not diluting the insulin for IV use. Mr. H's situation could not be reversed once the fatal insulin doses was administered. The only solution the hospital could provide is that of taking better informed precautions for any subsequent patients. In addition, physicians need not be doing complex surgeries when they are fatigued. Better preparation is the key when it comes to dealing with these situations and preventing fatal patient outcome. Unfortunately, Mr. H's blood sugar level fluctuated like never after his surgery, and as a result, he ended up passing away later that day. What went wrong in this case? Mr. H had major health issues as he suffered from diabetes, which is evidently why he needed surgery. Due to his age and current health state, he had kidney failure and needed transfusion. Mr. H's death after his surgery came solely from administering his medication incorrectly, thus leading to a fatal overdose of an insulin. The senior resident taking care of him was reckless and was unfortunately not attentive to detail. Mr. H's fatal overdose was due to the senior resident's lack of communication and not being fully alert when giving Mr. H the doses of an insulin. In addition, medical practitioners are often under an immense amount of stress and thus suffer from lack of sleep. Sleep is crucial in being able to perform at your best. Therefore, the senior resident who incorrectly gave Mr. H 10 shots of insulin may have been sleep deprived. The unfortunate truth is that disaster medication errors do have potential of occurring in any hospital or medical facility. This is related to miscommunication as well, as the senior resident didn't read back the order to confirm. Also, the medication which was supposed to be given for subcutaneous route was administered through an IV route. Senior resident also had a fear to confirm the medication with an attending physician. Once in my facility, while I have not experienced the disaster firsthand, there was once a patient who experienced a similar disaster hospital error. The patient was accidentally given an overdose of heparin, which then resulted in the patient dying from a brain hemorrhage subsequently. How can the issue be resolved? Unfortunately, there is a variety of reasons as to why medication errors such as these occur in medical facilities. Safe storage and dispensing, as well as monitoring the medication effects on the patient, need to occur as well, especially after the patient's discharge. However, most importantly, an evaluation of process and system must be established in order to further prevent medication errors in patients. First, the nurses and physicians need to identify the patient properly, as well as doing the medication check properly. If the order is unclear, it should be verified with the doctor and clearly repeated back. If there is any Questions related to the medication, it should be confirmed with the pharmacist. In addition, having a set rotation to allow the nurses and physician to have breaks and time to mentally relax is crucial. Sometimes nurses and medical practitioners are heavily worn down by the excruciating work they have each day. Thus, giving them proper time to step away from their work and take a break will allow them to be more alert and able to function properly. As mentioned in the case, the senior resident had been working non-stop all night. Sleep deprivation was likely a factor in the senior resident's inability to give Mr. H the correct doses. Although the blame falls on the resident, it also falls on the hospital. She was clearly sleep deprived, but was placed as the resident who was on call. All these precautions need to be implemented and practiced by hospitals and facilities, since this is a matter of patient's life and death. Who and what role do other disciplines have in resolving the issue? There are many ways in which these systems could be improved. For example, correctly ordering medication, transcribing vital information about the patient, and reviewing their medical history are some of those most important ways to improve these misses or near misses. While the senior resident was the person who gave Mr. H the incorrect doses of insulin, she's not the only person to blame. In addition to the senior resident, the entire department played a role in Mr. H's unfortunate outcome. The senior resident had been working non-stop all day since 6:30 a.m. and receives a call at 3 a.m. next day. Due to her sleep deprivation, she should not have been on call. Rather, the department should have chosen a different physician to be on call, given the circumstances of the sleep-deprived senior resident. What is your proposed solution? If the senior resident had realized her mistake prior to administering the insulin of Mr. H, he would likely still be alive after his surgery, thus being referred to as a near miss instead. What must be changed is that when any near miss that happens should be reported in order to provide a real-life learning experience of what not to do and what could be wrong. However, without penalizing the person in question if they had caught themselves in time. If anything remotely close to a near miss is reported, it will likely force the department to become stricter and enforce rules better. It will result in everyone in the department to keep a closer eye on one another and pay great attention to detail. If the near-miss situations aren't being reported, it makes it seem like there are no flaws with their current system, when they need to be stricter and make changes to lessen the risk of miscalculations and mistakes from happening in the future. I have not had a near-miss experience personally. However, a nursing colleague of mine had once given a patient an overdose of an insulin, thus resulting in the patient going into hypoglycemia. Fortunately, we were able to rectify the situation by giving the patient glucagon. As a result, I would say that this incident has caused me to be more careful while administering medications. What barriers exist towards implementing your proposed solutions? Hospitals' mistakes do indeed blame the who for incidents much more frequent than the how regarding these situations. Referring to the earlier near misses regarding the patient who was given the accidental overdose of heparin, the patient from a workplace died of a brain hemorrhage resulting from the heparin overdoses. As a result, the nurse is now incarcerated, fined, and both the hospital and nurse in question were sued. Subsequently, the hospital changed its policy and now need to double verify the heparin doses with another nurse. The rate change, the new bag should be verified with another nurse. The hospital's response to this error has made me more likely to report my mistakes due to all the legal repercussions that could happen as a result. In addition to the senior resident who miscalculated a doses for a patient getting in trouble, the hospital must take responsibility as well. Changes must be implemented and rules must be enforced rather than being brushed to the side.